Dr. Pascal, take it away.
Awesome. Thank you, gentlemen. Once again, it's a pleasure, Warriors, to be back on with you guys. So, in previous years, we would do, one webinar like this every 3-4 months, and we were targeting different areas of the spine. So we would do cervical, then thoracic, lumbar, and then we worked on scoliosis. But this year with Ed and Yuri, we decided that we're going to really focus on the cervical spine and become specialists and really dive in as much as we can in terms of cervical spine reconstruction, restoration, whatever word we want to choose to use there. So we're going to briefly touch on what we discussed on May 5th. So we're going to just really review the research very quickly. We talked about 2 key cervical measurements last time that I think are fundamental. They're the ones that I use the most. They're virtually the only ones that I really describe or talk to with patients about. And they're the primary ones that I want to look at on my pre-post x-rays, because I believe that those 2 measurements have the most clinical significance. So we showed you how to measure those last time, and we're going to do that again this time. But, not every single person needs a cervical Dender Rule, right? I would say 70% of my patients go home with a cervical Dender Rule, but the other 30%, they're kind of going to be scattered between either a thoracic Dender Rule, a lumbar Dender Rule, or maybe even using a scoli rule. But we want to know that 30% of patients that should not get a cervical Dender Rule, or don't need one, I should say, how do we determine if they're not a candidate for a cervical Dender Rule? So I'm going to show you guys today a measurement in determining whether the patient is a primary cervical issue we want to address or a primary thoracic subluxation, which is generally going to be thoracic hyperkyphosis if we're not using a cervical Dender Rule. And last time, if you guys remember when Ed was doing the introduction to the webinar, he discussed about when you start doing this in practice over and over, and you get really good at looking at an x-ray, and you could sit there and you can actually estimate what kind of curve correction is possible for a given neck or a given spine. And so what I want to do today is review a measurement that we can take on the patient's really what's called the thoracic inlet, the PTSIA angle, and that's going to give us a good idea of what kind of curve correction is possible for a given patient, whether that's 10 degrees, 20 degrees, 30 degrees, or 40 degrees. Again, just to help your clinical confidence, but to really improve your communication with the patients in terms of their outcomes in curve correction, and then also the length of time that it's going to take to get there, right? To not be scared to tell patients, man, this is going to take 2 years of correction to get you where you need to be. So we're going to hit on that a little bit. All right, so just again, a reminder and review, everything that I discuss is based on CBP. It's what I've learned. It's the research that I follow because I believe they're doing the foremost and best work in our profession. So anything that I discuss, if you want to look at the links to the research, cbpnonprofit.com. Again, they've got 240 papers supporting what they do. I think it's fantastic. When we're talking about just the cervical spine, there are 53 papers supporting the normal cervical curve and the restoration of that cervical curve using different types of chiropractic methods with traction. And in our case, we're specifically talking about Dender Rules, so we have 10 specific randomized clinical control trials that support what we do in practice as chiropractors, right? So we're not all necessarily doing this traction in office. We want to have subluxation-based chiropractic offices that focus on the adjustment, and those patients are coming in, they're getting adjusted, but we're adding Dender Rules to their care at home as an added tool that they can help to restore the curve to support the adjustments. Okay, and as we talked about earlier, those 2 measurements that we looked at last time were the increase in curve and the anterior head translation. Those are the 2 primary outcomes that those Dender Rule studies looked at, right? And the Dender Rule was very effective at reducing anterior head translation and quite effective at improving the curve, so much so that we could say about 3 sessions on the Dender Rule can increase our cervical curve by 1 degree, or 0.386 degrees of increase per session of use, right? Approximately 3 sessions of use, 1 degree of curve correction. So, again, those studies were done on the different sizes, and we size the Dender Rule based on the appropriate patient. Now, the better you get at this, the more you do this, the more you're going to understand that we don't just necessarily base this off of size, but if we're going off of just metrics alone, the large or the gray is for a patient that is 5'9" or above. The white would technically be 5'8" or less, or a more moderate sized adult. And then the yellow is a pediatric rule, or for your very small adults. That's based on size alone. but I'm going to tell you that more often than not, I base the Dender Rule the patient gets on their flexibility, how flexible their spine is. Because I have plenty of patients that are 5'5", 5'6", and I send them home on a large because they're extremely flexible, and the medium doesn't give enough force to correct the spine and the neck, right? And so at the end, we're going to go through 3 clinical cases where I'm going to show you different examples of patients who are tall and where we might place the Dender Rule at a different spot, or we would use a different size based on their stiffness. So very flexible, I always use large. Moderately flexible or a bit stiffer, I use the medium. And then my very rigid patients, I use a small. So often, I wouldn't actually even call this my pediatric rule. More often than not, I call this my geriatric rule, because a lot of my older patients that have pain, degeneration, arthritis, they're stiff, and they got all kinds of problems, I'm going to start them off or give them a small rule so it's tolerable, and then potentially build them up from there later on. So based on size alone, 5'9" plus gray, 5'8" or less white, smaller patients, pediatric patients would be the gold. Okay. Now, the 2 measurements we talked about last time that Dender Rule was trying to target are anterior head translation and total measurement of curve. So let's review those measurements. If we come over here to the right on the diagram, to measure anterior head translation, we start by drawing a vertical line straight up from the posterior superior aspect of C7. We draw a vertical line straight up, and then we measure the distance from our line to the posterior superior aspect of C2. That measurement, right, ideally the model that CBP created was 0. So in a perfect world, C2 sits directly over C7 and we got that nice C-shaped arc. But when we looked at that literature, so 400 plus x-rays of patients that had very normal necks, no symptoms whatsoever, no degeneration, healthy looking x-rays, up to 15 millimeters was acceptable or considered normal. So 15 millimeters or less is what we're trying to target. And in a perfect world, we're trying to get them to 0. So anything above 15 millimeters, that's a valid measurement of subluxation on x-ray. We want to reduce it. And the Dender Rule is a tool, like you can see over here. It's a valid tool to be able to reduce that curve in the neck, okay? And so any patient that has anterior head translation, but it has to be less than 50 mils, right? We're going to talk about why that is today, because above 50 mils should be sending off alarm bells in your head telling you to look to the thoracic spine. Because once we start having very large anterior head translation, oftentimes that large deformity is being driven by an increased rounding in the thoracic spine. So 50 mils or less, we can use the Dender Rule to reduce that. Total measurement of curve, right? So we have our diagram here on the right. We see that black line, and that black line is running parallel. It's running, I should say, tangent even to the back of C2. So I draw a line straight down. I draw a line straight up from C7 that hits the back of C7, and that creates this intersecting angle over here, right? And that angle is our total measurement of curve. In mechanical engineering terms, they say the ARA. For us, not important. We'll just call it the curve. And the model was 42 degrees, right? That's the ideal. Now remember, the population normal was 34 degrees. So I'm always happy if my patient's neck sits somewhere between 34 and 42 degrees, I consider that a normal neck curve. Now, again, later on, I'm going to show you that there are going to be cases that'll never get to 34 or 42 degrees because they don't have the proper morphology to be able to get this high. So it's important to know those cases that are going to fall under these values, okay? And so, a subluxation is when a patient's neck curve doesn't meet their pizza angle or their morphology. And so again, it gets a little bit complicated, but we're going to try and explain this as clearly as we can so that you guys start to understand that, yep, this neck does not meet the morphology, subluxated, we need to curve correct. So anytime we have a reduced curve and we have anterior head translation, as long as it's less than 50 mils, we have a candidate to use a cervical Dender Rule to improve the curve, reduce the head translation. All right, so what about those cases, like I mentioned, that start to push larger than 50 millimeters of anterior head translation? Well, I have to start thinking about a thoracic problem, thoracic hyperkyphosis, okay? So if I see large anterior head translation, over 50, but sometimes even a little bit less than 50. If I'm in the high 30s and 40s, sometimes that can still be generated by thoracic hyperkyphosis. So how I'm going to estimate that is I'm going to go down, I'm going to take this next measurement, which is the slope of T7, and T1 relative to vertical. That is an indirect measurement of my thoracic spine, okay? So very low values, right, close to 0, very low values tells me that the thoracic spine is very flat. Very high values of C7 and T1 tell me that I have a very rounded or likely thoracic hyperkyphosis. So I'll show you guys how to measure this, and I'm going to give you cutoff values that above those values you do not use a cervical Dender Rule. You take a lateral thoracic film, or if you're not taking lateral thoracics, you use a thoracic Dender Rule, okay? So this is large anterior head translation. Think slope of C7 and T1 because we're thinking it's a thoracic problem. All right, so here's an example. I have this large anterior head translation, 72 mils. So it's above my cutoff of 50 mils. So in this case, if I was to take a lateral thoracic film on this patient, I would likely see that there'd be a large rounding in the thoracic spine that would be quite responsible for pushing this head so far forward, okay? So in a case like this, if I use a cervical Dender Rule, what's unique about the cervical Dender Rule is that it's also designed to increase or normalize the thoracic upper kyphosis, because you cannot have a normal cervical curve without having a normal thoracic kyphosis. Let me say that one more time because it is so important. I think it's often why we struggle to get good curve restoration. You can't have a normal cervical curve if you don't have a normal or close to normal thoracic upper kyphosis. So if I'm already hyperkyphotic or I have too much rounding, the design of the Dender Rule is just going to keep that deformity there. I might improve this patient's curve, but they're going to have a curve and their head's going to be still 2 inches forward, which is no good. So in a case like this, if we flatten the thoracic spine and we decrease the kyphosis, we're not only going to improve the curve, we're going to get the head back. So by addressing the thoracic spine in a case like this, we're actually going to get better cervical results than using a cervical Dender Rule, okay? And so here's the other measurement we take to know if it is a thoracic problem. So if I see that large anterior head translation, I'm going to measure the back of C7 and T1 relative to vertical. I'm going to go slow. I'm going to try and be as clear as I can. If there are questions when we open it afterwards, we'll come back to this because I want to make sure this is crystal clear. Now, we give you 2 measurements. We give you T1 and we give you C7. Ideally, we use T1, right? Because that's the one that we're going to use to estimate the total amount of curve. But on those very broad-shouldered people that are very thick in the collarbones, sometimes we don't see T1 very well on an X-ray, so we default to C7. But if you can see T1, let's use it because it's more accurate, especially because we're using it for curve estimation. So I come down to T1. Right? I'm doing that same idea of that vertical line. So I draw a dot at the back of T1, posterior, inferior aspect. I draw a perfectly vertical line straight up. Then I draw that line that follows the back of the body of T1. I draw it straight up and I get this measurement right here, okay? The ideal value is 26 degrees. So if I see 26 degrees, that means my patient has a normal thoracic kyphosis, right? Which would be approximately 44 degrees, okay? If I start seeing values that are less than this, it means the thoracic curve has reduced or has flattened. If I see values well above this, it means my thoracic spine has increased in rounding or I have too much hyperkyphosis, okay? And so again, like this says here, you can't have a normal cervical lordosis without a normal upper thoracic kyphosis. And oftentimes, as that neck straightens and goes forward, it flattens the thoracic spine. So as we use a Dender Rule to improve the cervical curve, we're also going to increase that upper thoracic kyphosis, okay? And let me explain. I'll just draw it out so this maybe makes more sense, okay? So if I had a very flat cervical neck curve, so let's just say this is the back of my neck curve here, and it's very flat. There's very little curve, and I can even try and bring that into like a thoracic kyphosis. So let's just say, my C7 would start here. That's the body of C7, right? And my atlas plane angle is up here. So if this is my C7 and then this is my T1, I'm trying to draw a vertebrae freehand here, so forgive me. If I draw a line straight up from vertical, you can see there's virtually no angle here, right? It's very flat, and my thoracic spine would be flat the whole way down. So small, low values indicate flat spines. Now, alternately, let me erase all this. If I had, some anterior head translation and I had a really large thoracic kyphosis, I'm exaggerating it. But now if I had a C7 like this and a T1 like this, and I drew my vertical line up, now I'm looking at angles of like 50 plus degrees. So I hope everybody can see that the larger this angle, it means that we're really tilted in these vertebrae, and it's indicative of a large thoracic kyphosis. Okay, so we measure this angle here to tell us whether or not we should use a cervical Dender Rule. So my absolute cutoffs that I use for myself are 30 degrees at T1 and 25 degrees at C7. So any value above 30 degrees, stop, not a cervical case. I think thoracic spine, generally a thoracic Dender Rule. Any value here, if I can't see T1 above 25 degrees, stop, I use a thoracic Dender Rule, not a cervical case. 30 or less, ideally 26 or less is always going to be a cervical. 21 or less, always a cervical. Okay, so those are kind of like those threshold cutoffs where, your spidey senses should be going off if you're seeing values above this. Let's show you some examples on X-ray so it makes more sense. So here's the normal curve, right? We got C2 directly sitting over C7. We got a 42-degree arc, no anterior head translation. If I drew my line up, and see here, you could barely see T1, so we could use C7, but let's say, that's the posterior aspect of T1. If I draw my line up, I take that measurement, it's approximately 25 degrees, beautiful. Come over here, right? Green is the reference line of where I'd want my patient, red is where this patient is. So this patient has 7 degrees of curve instead of 42, so it's reduced. Patient has 16 millimeters of anterior head translation, so a little bit of anterior head translation. So on these two measurements alone, I'm thinking, yep, perfect candidate for a cervical Dender Rule. I'm assuming based on those measurements that they're flattened, they're reduced, the curve is reduced, that I'd probably have a flat thoracic spine. So let's confirm that. Let's go to T1. I'm going to draw my line up. Okay, I had measured this before, so I know what the measurement is. It's 18 degrees at T1, and it's 12 degrees at C7, right? So 12 here is under my normal of 21, 18 is under my normal of 26. I assume that this patient has a flattened thoracic kyphosis. They've got reduced curve, anterior head translation, perfect candidate to put a cervical Dender Rule on because it's going to improve the neck curve and slightly normalize or help to increase that thoracic spine a bit, okay? Now here's a case where I would not use a cervical Dender Rule because my spidey senses should go off. This is a thoracic hyperkyphosis case. His neck curve is 35 degrees, okay? So we're already getting into that normal realm there. His anterior head translation, though, is only 37. So it's not quite above that, black and white cutoff of 50. But still, because the curve is normal, it's not really reduced. I've got high anterior head translation. So I tell myself, let's go check out what's happening in that thoracic spine. So here's C7, here's T1. I'll use T1 because I can see it clearly. I'm going to draw my line up. I'm going to take this measurement, and I'm going to be 45 degrees. That's way above my cutoff of 30 degrees. Spidey senses should be going off that this is a thoracic hyperkyphosis case. I do not use a cervical Dender Rule in this case, right? Ideally, I'm going to take a thoracic X-ray, so here's that same type of neck. I take a thoracic X-ray, and what you're going to see is this large rounding in the thoracic spine, right? Increased rounding. My thoracic curve should be 44 degrees, right? So when I start getting values in the 50s and 60s, I need to address this to improve the neck curve and reduce the anterior head translation. If I just put a cervical Dender Rule in right here, right, it's pushing on this area, right? Great. It might improve that neck curve and we might get a better curve, but the head's still going to be forward. And I'm leaving the patient with this large thoracic hump or this thoracic hyperkyphosis. And that's why we don't want to use cervical Dender Rules in this case. We're better suited to use a thoracic. We'll get better curve correction in the cervical spine and better overall patient results. Okay. Now, let's talk about estimating some curve. So now we've determined that the patient is a candidate for a cervical, right? They've got reduced curve. They've got less than 50 millimeters of anterior head translation. And those values of C7, T1 will say are normal or slightly reduced. So we know we got a good candidate for a cervical Dender Rule. Now I want to try and decide how much curve correction is possible for a given patient. So we're going to take this big ugly term here, posterior tangent sternal incidence angle. Again, these fancy mechanical engineering terms. What this really means, this is a morphology measurement. We're measuring the patient's bone structure at their thoracic inlet, And that lets us determine how much curve is possible based on that thoracic inlet, okay? So let's check this out. So this line here was measuring that slope of T1 and we just finished talking about, right? So that vertical line up from the base of T1, there's that slope line behind T1, and that was my measurement there, right? We wanted to be normal or ideal was 26.5. So this is why I said use T1 if you can, because now you already have your line drawn behind the body of T1 that we can use to measure our morphology, or what we call the pizza angle, posterior tangent sternal incidence angle. So I take that posterior body line. Now my X-ray, ideally, I'm going to see the top of the manubrium sternum, or where the front of the two collarbones meet, okay? That's the sort of the top of my sternum. So I put a dot at the top of the sternum, or where the two collarbones meet on the front, and I bisect, or I connect the line from the top of T1, posterior superior aspect, all the way down to the manubrium sternum. I measure this angle, and that is my measurement of thoracic inlet. The ideal that goes with that 42-degree neck curve is 73 degrees. Okay, so if I have a 73-degree pizza angle, I'm assuming this patient can get a 42-degree neck curve. But not everybody is going to have an ideal or perfectly normal pizza angle. There's actually going to be a ton of variation. You know, maybe you'll have a bunch that are 71, 72, 70. You're going to get some down in the 60s. You're going to get some down in the 50s. Rarely, I mean, throughout your career, you'll probably see a few in the 40s and 30s, but those are ultra rare, and those are patients that have like completely reversed curves everywhere in their spine. So I didn't give you measurements for those because they're so rare, and those ones, I wouldn't say I've seen enough patients, or Dr. D has seen enough patients to give you a true estimate of what's possible, okay? But before we give you the curve correction, let's talk about the other end. If it's over 75 degrees, again, thoracic hyperkyphosis. So people with very large thoracic inlets are going to tend to round in the shoulders more. They're going to tend to have thoracic hyperkyphotic problems. So again, this is sort of another check and balance that we can use to see if it's a thoracic case and not a cervical case. So if it's above 75 degrees, you're thinking thoracic, not cervical. These measurements, as far as we know, are more or less fixed. Like this is a morphology, a bone structure measurement that changes slightly, but it doesn't change a ton over time. This is not something where I start at 50 and I re-X-ray, 2 years later on and they're at 75. It doesn't work like that. I've seen 4 or 5 degrees of variation, and some of that might be human error of measurement, but imagine that these are more or less fixed values. They're morphological values based on bone structure, not things that we can really correct, okay? So if I see a pizza in the 50 to 55 degree range, I'm assuming that patient's going to get about 10 degrees of curve. 55 to 65 degrees, I'm assuming 10 to 25 degrees of curve. And then lastly, 65 to 75 degrees is close to my normal range. I'm assuming 25 to 45 degrees of curve. So for instance, if they're closer to 65, well, I'm thinking the top end will be about 25. If it's 75, I'm thinking 45, Likewise in here, if my patient has 55 degrees, I'm thinking closer to about 10 degrees than I am 25, right? If they get closer to 65, then that's the higher interval there. Now, these are just approximations or estimations. Dr. Deed is working on a formula right now where you're going to be able to just actually punch in the person's pizza value to this formula, and then you're going to get the exact measurement of curve that that patient should be able to achieve for their pizza angle. So they have statisticians currently working on trying to build that formula for us right now. But for now, this is the best estimation that I can give you. So you can use this, so you can tell a patient, hey, you got a 50-degree pizza, let's try and get a 10-degree curve in your neck. You got another patient that comes in with a 65 degree. Hey, let's try and get about 25 degrees of curve in your neck. So this helps guide you a little bit to help you know what's possible, but also to meet patient expectations and give them, good recommendations for care. All right, so let's put this all together. Let's talk about a few cases and see if we can make sense of this all. So we got a male here, 6'1", okay? He's fairly tall and he's very flexible. So automatically, right, I'm gonna assume it's a large Dender Rule. But let's check our other measurements to make sure he's a candidate. His curve is 10 degrees. Check, right? It's reduced. Anterior head translation, 29 mils. So it's less than 50, right? It's not bordering too high. It's up there. It's significant, but looks good to me. So I go down. I want to check his C7 and T1 to vertical. I've got 18 degrees at C7, so just slightly reduced. And then T1, I've got 28, just slightly increased. So, average these those two together, and more or less, I have a normal thoracic kyphosis here, okay? That's a good sign. He's got a normal thoracic kyphosis, because remember I told you, you can't have a normal curve without having a normal thoracic kyphosis. Well, we're starting with normal, check, that's great. I come down, I look at his pizza angle, 75 degrees. He's actually just a little bit above that ideal for 42 degrees. So he's bordering on, if I had seen 78, 79, 80, I'd be thinking thoracic hyperkyphosis. But he's got a normal thoracic kyphosis. He's got a normal or just slightly high pizza. I look at this and I think, wow, this is going to be a curve that's going to correct like crazy. I'm expecting to get this guy as close to normal or ideal as possible, okay? Let's talk about Dender Rule placement here for a moment. So I'm going to use a large. But when you have large anterior head translation in a case like this, almost 30 mils, and if I look at my green ideal arc, right, and I see the patient's neck curve here, so all the bones in red, I notice that every single vertebrae in the cervical spine is anterior of where it should be. In cases like this, when I have large anterior head translation and I want to bring the head back as far as I can, I want my peak low down. So in this case, I'm putting my peak at T1, C7, so it allows curve to be induced, but to also reduce as much anterior head translation as possible. So large anterior head translation, peak low down to reduce that and improve curve. I'll show you some examples of where we don't place the peak there in a minute. So again, I tell the patient this should be a great curve, correction if he follows through with my recommendations and is consistent, and the patient was. So here's pre, right? And here's post 3 months of care after our first, corrective care plan. So, when we do it at CBP, we tell patients it's going to be a year, but we check in at the end of 3 months of correction before we slow their visits down to twice a week. And what we do is we take an X-ray to check and see where they're at. And so now after 3 months, post X-ray, this is where this guy is at after using the Dender Rule almost daily and using the prolordotic neck exerciser here in our office. He's got a mid-30s neck curve, virtually no anterior head translation left, and again, those values of C7 and T1 maintained their normal position. He's got a normal kyphosis and almost a perfectly normal neck. Check, excellent correction in this case. But they're not all going to be that good, right? Because not everybody's going to have those perfect measurements like he did. So let's go to a second case, right? That is going to be very similar in height, 6'1", same flexibility, very flexible, almost the same amount of curve starting, 13 degrees. But let's look at a few different things. Instead of having large anterior head translation, he's actually got negative. So his head is actually almost 5 millimeters backwards. So that's going to change where we're going to place the peak of the Dender Rule. We're going to come down to his C7 and T1 relative to vertical, and we notice that both of those values are reduced from normal. So I know this patient has a flattened thoracic kyphosis. Now I want to know what's normal in terms of putting curve back in his neck. 56 degrees. So if I had jumped back 2 slides, and let's go back to, right? So if I go back here, and let me erase all this ink, he's got 56, so just above this, right, kind of on the low end here. So on the low end, 56, I'm thinking, 10 to 15 degrees of curve. He's already starting out with 13 degrees, right? So I'm thinking, oh, should I even correct this cervical spine? He's got 13 degrees. But in cases like this, oftentimes there are things that we have to work on. Even though we can't necessarily get his curve to 42 degrees, these patients all still benefit functionally from stretching their spine in the proper direction, taking stress off the brainstem, the spinal cord, the nerves to allow proper function. Okay, so I tell this patient, yeah, maybe you got 13 degrees here. Maybe we're going to get you another degree or 2. But if I look at his curve, I see a kyphosis here, seeing 3, 4, and 5. He's kyphotic up here. I come down here at C6, C7. He's got too much curve low down, and he's got a reversal through here. So even though he's got 13 degrees, his neck curve looks terrible, and I know that this kyphosis is going to cause problems, and this instability or hyperextension is going to cause a problem. So I'm going to tell this patient, yeah, we're going to try and improve your curve a little bit, but what we're going to do is we're going to put the Dender Rule right here. We're going to drive that forward. We're going to try and reduce that kyphosis and hopefully reduce that hyperextension at C6, C7 for an overall better neck curve and better functionality for the spine and nervous system. So here's a stress X-ray. So I put this patient on his back on a Dender Rule, snapped an X-ray, and then I just flip it so that we can look at it like as if he was standing. Okay. So here's the peak of the Dender Rule, right? Pushing right at the kind of the base of that, where that kyphosis was at C5. You could see it reverses the kyphosis beautifully, and it actually reduces the amount of curve or hyperextension at that C6, C7. Okay. So it's the exact result that I want. Great. Okay. Now I come though, post X-ray 6 months later, right? And so 6 months later, what I notice is very little curve correction, but that's what I had assumed based off of his shallow pizza angle, right? We're now sitting at approximately 15 degrees of curve, probably the top end for this patient, but we've reduced the kyphosis. There's still a bit more work to be done, and maybe if we had placed the peak of our Dender Rule just a hair higher, it would have been a little bit better, right? But so we've reduced the kyphosis, and we've reduced the amount of hyperextension or instability at C6, C7. So he's got a slightly better neck curve, but overall a much better position, functionality, spine, and nervous system. So this is a successful correction. Now, if I don't understand this though, after 6 months of this patient laying on a Dender Rule and doing exercises, I might be batting my head against the wall and being frustrated. So this is where it becomes crucial for you to have that clinical excellence and know what you're doing, because you would see this on a post X-ray and say, yep, that's a fantastic result for this patient. Let's keep going. Okay, last case, then let's open it up for questions. We've got another male. He's 5'10", right? So again, he's theoretically supposed to be a large cervical Dender Rule, but he's a little bit more rigid, right? He's in his mid-50s. I look here, he's got some pretty significant phase 2 arthritic change, maybe even starting phase 3, right? So based on that, I'm going to say, let's use a medium Dender Rule. But there's another caveat here. This patient comes in with a significant disc herniation and tons of pain. So he's got a disc herniation at C5 and C6, and then a small one at C6, C7. He comes in with his hand above his head and a positive Bocodi sign. Okay, I'm actually going to start this patient on a pediatric because he's rigid, in pain, he's got arthritic changes, and he's going to have very little mobility, and he could tolerate very little. So he starts on a small pediatric Dender Rule. But before we get ahead of ourselves, let's just make sure he meets the other criteria. So he's got a reduced curve. Check. 28 millimeters of anterior head translation. Check. Cervical slope, or pardon me, C7 slope to vertical, 10 degrees, so pretty significantly reduced. T1, 18 degrees, significantly reduced. So I know he's got a flattened kyphosis. Yep, he's a good candidate for a cervical Dender Rule. Now let's estimate what kind of curve correction is possible. 66 degrees, right? If we go back here, what do we say? 66, so just above here. So, 26, maybe 27 degrees of curve. However, in this situation, knowing how stiff and rigid he is and how much arthritic change he has in his spine, I'm not going to promise him that top end. I'm going to tell him, hey, we're shooting for high teens, maybe low 20s in your case. And if you continue through with 2-3 years of care, and we work hard to really work at this over the course of a care plan of 2 to 3 years, can we correct this into the mid-20s? Maybe. Absolutely, we could try. But don't promise them this, in that first year care plan. Be careful with what you promise, because these cases are going to be trickier and take longer to correct, okay? And so here is this patient's neck curve after 6 months using a pediatric Dender Rule. So we place the peak right here at that kyphosis because I want to drive that aspect forward, right, to meet my green reference line. And I want the top part of my curve to come back to reduce anterior head translation. So he started at 4 degrees of curve. 6 months later, we're at 13. So a 9-degree improvement. We've reduced the kyphosis, reduced the anterior head translation, improved the atlas plane angle. Beautiful correction for a guy in his 50s with a disc herniation and tons of problems. So at this point, I gave him medium Dender Rule to continue on with. And unfortunately, this is a patient that I haven't seen in a couple years. He moved back to Korea. They had some troubles, I guess, and they couldn't continue on. And so I have no long-term follow-up. I would have loved to have seen where we could have gotten to in this case. However, knowing where he started to where he left, significant improvement, and hopefully he's continuing on with his exercises. For other details about using the cervical Dender Rule in terms of time and how to place it for the patient and how they should get off and when to ice and so on and so forth, go to my YouTube channel. I've done some small 5-minute videos where I describe sort of the indications, contraindications, and how to use all the Dender Rules, but you could find the cervical ones there. If you have questions about specific cases, please email me, but give me a few days. I don't answer this email every day. I check it about once a week to look at cases. Okay, here's the website in which you order Dender Rules from if you have not been there yet. And then lastly, again, as a thank you for being on the webinars, for being loyal to the Dender Rule products and trying to move our profession forward in terms of reconstructive chiropractic, here is a coupon code that you guys can use for the next 2 weeks. That'll give you 10% off your orders of Dender Rules. So that's all I have for you guys. We can open it up for some questions and see if we can dive into some more details.